Hello, everyone. So it is my great honor and privilege to be present in this conference, and I'm thankful for all the organizer for inviting me to talk at this conference. So I'm Shahzad Zafar. I'm a pediatric neurologist and epileptologist. Currently, I'm at Duke University Hospital. I'm the director of Epilepsy Monitoring Unit, and I will be talking more about the neuromodulation in epilepsy, and that's the topic I was given. It was given to me. Especially, they told me to talk about RNS and DBS, so which I will talk a little bit. So I have a training in pediatric and neurology and then epilepsy. So in my currently practice, I see children and adults with epilepsy who are refractory to medication. And then that's how we use this neuromodulation. And that's part of my practice, what I do here. So let's move on. So first I will start with, rather than going to RNS and DBS, I wanted to just talk about the neuromodulation. What is neuromodulation and why we do neuromodulation? We have many anti-seizure medications. So what is the role of neuromodulation? So just the background, so you all are very familiar with it. 30 to 35% of the patient population have of epilepsy will not respond to medical management or medical treatment. We call them medical refractory epilepsy. The new name is drug-resistant epilepsy, or DRE. There are multiple studies done. I'm quoting one of the studies. So there was a study in 1990s, then in 2000, and then as early as 2010. So the theme is pretty much the same. So I just want to summarize one of them. So if I have epilepsy and I start one first medication, there's a chance of 47% or 50% I will respond to that medication. If I fail, I add a second medication, then there's a 13% more chances that I will respond to the second medication. And after that, if you see, if I add the third medication or fourth medication, the number do not increase. And with our best treatment, so the number do not go up above the 70% mark. And this is from multiple studies. So we are left with 30 to 35% of the patient population that do not respond to medical management. And then we started thinking about what else can we do to help them. So in our mind, or in my mind, the resective surgery is the cure. All other things, we are controlling the seizure, including medication, including the neuromodulation devices. They are not curing seizure, they are controlling. So resective surgery, in my mind, or how I was trained, that this is the cure for epilepsy, this is on top. But unfortunately, not all patients are candidate for resective surgery. So then we end up either polytherapy, or if they are candidate for neuromodulation, which is VNS, RNS, and DBS. And so we'll focus on that neuromodulation. So what is neuromodulation and how we use in the epilepsy? So I think the underlying premise is that there's an electric circle model of neuronal function, and either direct or induced electric current can modulate the network activity, and thus can control or abort the seizure. I think of this way, just like we are using the medication or the seizure medication, they are either increasing inhibition or decreasing excitation. They are controlling the balance. So that's, I will say, chemical modulation of excitation and inhibition. So versus we can move into electrical neuromodulation, like can we use the electricity to get the same outcome? So it is not a new theory or new proposition. So it has been going on in the centuries. So one of the reported one is in 19th century. So Giovanni Aldini, he was the nephew of Galvani Luigi. So he treated, this is back in 19. So he was more into electricity, and then he was using the the autopsy patient, and then or animal or human, and trying to see if we can generate electricity. He was doing all sort of experiment. So he did experiment on a patient who has melancholy or depression, and he treated with electric stimulation of head. So this is one of the earliest case report or written evidence of neuromodulation. And then since then, it is our sophistication of neuromodulation has advanced dramatically. We have multiple advanced devices to stimulate safely and to the target. But the underlying premises is the same, that electric activity is the source of both function and dysfunction of brain. and can we harness that as a treatment modality? So from there to now, so now we're going to see how we can use this theory or this mechanism to our advantage. So today, I think we'll talk, there are many more neuromodulation, but I will talk about mainly RNS and DBS, which is responsive neurostimulator and deep brain stimulator. But I do want to also give the background with the vagus nerve stimulator, and that was, I think, prototype, and then we go on to the next one in deep brain stimulator. So let's start with the RNS, or sorry, vagus nerve stimulator, or VNS. So that's one of the oldest one, approved in 1990. So even in the 19th century, people started to think that, or hypothesize that there is a role of vagus nerve in the seizure production. Whenever we have the seizure, there's increased blood flow to the brain. So can we modulate the vagus nerve to decrease that blood flow to the brain? So that was, I think, just a theory from someone, but then it was not performed in human until a century later. It was approved by FDA to use in human in 1997. Initially, it was 12 years and above, but now the indication has gone down to 4 years. As an off-label, we use it even younger patient too, but FDA approved for 4 years and above. And then one other thing I want to mention, it is only approved for partial epilepsy and as an adjunct therapy, not the generalized epilepsy in USA. But in Europe, it is approved for both partial and generalized, and other countries it can be, but in US, it's only approved for partial, but we use it as an off-label for all epilepsy. So just a little bit of technical. So there's a VNS stimulator. They place it under the chest. Oh, sorry, under the skin. It's above the muscle, it's above the chest. You can feel it, you cannot see it. There's a scar of almost the size of your finger is up there. So that's a cosmetic reason it's there. And then the wires are wrapped around the left vagus nerve. And the thought is the left vagus nerve go innervate the AV node, or atrial ventricle node, versus the right vagus nerve go to sinoatrial or SA node. So the thought is if we stimulate the right vagus nerve, there's a more chances of bradycardia or heart rate decrease versus the left vagus, which innervate more to the stomach. So that's why the rationale of putting the left side, but we have many patients who are right-sided if they have complication from the left, so we can move to right, and they do equally good. But for all practical purpose, it is all the surgeon, everyone we place on the left vagus nerve. So there are three mechanisms, and this is how we tell parents that there are three defense mechanisms that it can stop the seizure. First is a regular mode. It is continuously firing all the time to decrease the excitation of the brain. We don't need to take any, do anything. It's just like a medication is going on in the background. Second is if someone sees, or some patient or some caregiver notice a seizure or coming seizure, they can swipe the magnet, and that can give a little bit bigger burst to hopefully to stop the seizure. It's more like rescue medication, Diastat and midazolam. Parents get or the patient get a little bit more control. Okay, if I'm in partial seizure, I can swipe it. It can decrease the seizure duration. It can decrease the post-ictal period. I still have not seen anyone stopping the seizure with the magnet. Maybe it decreases the post-ictal and frequency, but it will give a good kind of mental or control to the patient. I can stop it. I have something. I'm not helpless. The third is the new one is auto stim mode. That's, I think, in the same 6-7 years, last 6-7 years it came. And they started to make this as a market as a closed loop. And I will talk about closed loop when we talk about RNS. So basically idea is it can detect the heart rate, and moment there's an increase in heart rate, which is not normally when we exercise or run, but more than that, very sudden increase in heart rate, this will detect and it will fire. It's kind of like closed loop with detecting heart rate and firing when you see that. The problem with that is we are all a neurologist. We are biased that unless you have the EEG confirmation, you cannot say that it's seizure. It's just a heart rate increase. So there's many false alarm for that too, but that's fine. It does not hurt anyone. But what point I'm making is that they claim it's a closed loop. It is kind of closed loop, but it's really not. So that's the point about the auto stim. But there are three different mechanisms that it works. How it fires is a square wave pulses. And again, I won't go into detail, but if you can see that, let me see if I can. Yeah. So if you can see that there's a square wave pulses, so that it send a pulse like this, and we as a neurologist, we can change it. We can increase the current to that. We can increase the time it fired. We can decrease the duration in between. So it's all the time it firing like this. One can argue, why don't we just send it all the time? So one, there's not much, there's not data done in human. There's some in animal models. Then the battery life like run is uses more, is less battery life. So there's that's what the balance came in. Okay, we'll fire every 5 minutes, we'll on for 30 seconds, off for 5 minutes with this current. If needed, we can decrease that to every firing every 3 minutes or every 1 minute. So that's the on and off phenomena. And otherwise, usually we just adjust the current, start from 0.25, keep going up to 3.5. And then after that, then you decrease the interval in between. So mechanism of action, so very briefly, so one is it could be that this desynchronization of network activities. So vagus nerve, all the sensory nerve go to the through the brainstem to the thalamus, and from thalamus it goes to all the somatosensory associated cortex. So can we decrease that or abrupt that pathway from the thalamus to the cortex? So that's, I think, one of them. Exactly, we don't know how it works, but one of the mechanism is maybe there's a direct stimulation of the brainstem nuclei that goes to the thalamus, and it disrupt or desynchronize the cerebral rhythm. That's one. Second is it's not going to thalamus in itself. In the brainstem, there are a lot of nucleus there, all the sensory nucleus there, all the neurotransmitter released from that. So can it cause any effect on that on the local brainstem level? So when they did a CSF of the individual with VNF, they noticed that decreased level of aspartate, and which is excitatory, and then increased level of GABA, which is inhibitory. And then in a similar, can it release norepinephrine? So I think there are a couple of theories. Exactly, we don't know, maybe combination of all of that. So that's why it's more broader effect rather than one targeted, which is more with RNS, which I will talk. So little bit about data about the efficacy. So something to back that up. So there's a preclinical data in animal model in 1986. They noticed that if we stimulate the vagus nerve, it will decrease the seizure in a primate model. Then later they did that on the rodents, and they also noticed that if you stimulate the vagus nerve, it will not stop the seizure, but will decrease the frequency, it will shorter and going seizure activity. So based on that, then we started using, okay, why can't we use in the human? So the first clinical trial came in 1991 that showed efficacy. And then once it ended in 1997, around 1995, then it was approved in 1997 by FDA. But that was the first clinical trial. We have a lot of data, research data from VNS, since it's the oldest neuromodulation. We have 30 years of data. So people started doing meta-analysis, looking at it, okay, what are the predictors, who will do better, who will not. So one I will mention a couple of meta-analysis. One was in 2011. So they noticed that, so for the patient who had the VNS, there's average reduction of 45% of seizure. That's one thing they noticed. The second interesting thing they noticed that they started to notice that the efficacy increased with time. So it is 36% at 1 year, 51% at 12 months, and then later study have shown it goes up to 65% in 5 years. So that's the second important thing they noticed. Third thing they noticed that children can do well, also is approved for 12 and above, and also is approved for partial epilepsy, but generalized epilepsy also respond. Then there are two other meta-analyses I will mention, one in 2015, second was a Cochrane review. So the second thing they mentioned that high stimulation, not the current, but the frequency, meaning if you decrease the off time, so it fire more frequently, that has little bit better response than the low frequency. And then lastly, there was 2-3 studies in 2010 and 2015 that they're saying that the younger patient actually do better, although it is not approved at the time. But the idea is earlier you treat epilepsy, outcome is better, you respond better, rather than someone who's having long-standing epilepsy and you put a VNS. So it's contraindicative. We think, okay, children, let's not do it. But I think evidence and data is showing that we should do it early. So then a couple of things about other thing to consider. So side effect VNS, essentially it can cause the vagus nerve or the branch for that go to the innervate the vocal cord, so it can get affected. At higher current, you can get cough, dyspnea, hoarseness, and little bit of pain, although it's very, very, very rare. And usually when you have that, you just back off, just like any medication, you back off the dose, then try again, and then usually they started to tolerate it. Second point is MRI compatibility. So it's a magnet, it's a VNS. So you can do the MRI of the head, but MRI of the chest and the trunk, there's a specific criteria, which area you can do, which not. So essentially the chest MRI, cardiac MRI is excluded. And you have to turn off the VNS during the MRI and turn it back on after the MRI is finished. Other point about the device remover, let's say if it's not working. So shall we remove it since it's not doing it? So it can go either way. I think is rather than making someone go through another surgery, just leave it on. Maybe just turn it off if it's bothering, but otherwise just leave it on. Battery life is usually 5 to 7 years, depending on how fast and how high the current is. And then that's I talk to the patient that you have to go for another surgery at 5 to 7 years. Although it's ambulatory, an hour or 2 hour surgery, but just to consider surgery as its own risk and everything. So that's the vagus nerve. Then let's go to some interesting part of the RNS and DBS. So I'll start with the responsive neurostimulator because that was approved first, and then we'll go to DBS because that was approved later. So RNS. So I think the main thing that they're marketing or main thing that attract everyone is the closed loop, meaning that it will fire only when there is detection of ongoing EEG activity. Compared to vagus nerve or DBS, which fire all the time, this will only fire if it detects seizure. So how we do that? So there's a combination of electrocardiogram. You have to have either subdural or depth electrode. So here in this picture, that this is the marketing picture from RNS. So you can see one is they put a subdural and then one the depth electrode. Trying to see it could be either subdural or depth electrode. So this will keep recording all the time. So that's one. Second thing is these not just only record, they can stimulate too. And the third thing is some kind of circuit that is a closed loop. So from here, you can see that it's recording EEG and there's a computer, or I told parents it's a sophisticated small computer or a chip that will record EEG. And then once it knows seizure, it will fire back a stimulus to stop it. So you can see the example that EEG is recording. Moment it detects seizure, it will fire and it will stimulate it. Just like an automatic cardiac defibrillator, it will lock onto the heart rate. And whenever during the EKG cycle, when you see abnormal rhythm, it will fire to abort it. So I think a couple of things from that is technical, which I will talk in later. As a practical mean, like how to train that computer to pick seizure. Every human has seizure, different kind of seizure. You cannot make one model, this is the seizure. So detection parameters are not well defined. So it's more individualized, it's long hours, sit in the clinic, troubleshooting, what kind of detection. And then the even harder part is how to stimulate that. What is the frequency? How was the current you stimulate? So these are the two things I will talk a little bit more. So this is again showing the same picture. So how does the electric stimulation can stop that? So I think that going back to either could be causing depolarization block. It's not letting the depolarization wave passing through. It may be causing synaptic inhibition. It's inhibiting the synapses between the two neuron, or it is modulating the pathological network that, so let's say if there's not a focal epilepsy, it's a regional epilepsy, it's a whole network involved. So maybe it block it or it abrupt that network modulation. So in US is currently one device, it's approved by FDA, it's called NeuroPace, is the name of the company or the device they make is an RNS system. So it can put 4 electrodes, each will have 4 contacts. You can put 4 depth electrode, 4 subdural electrode, and you can put on wherever you think is the epileptic area. Only thing is only 2 electrode will be active at one time for stimulation, and then other are there, and then you have to change that. It's a small surgery, not the open craniotomy. They have to change from the on the top, the generator, put other electrode that you want to be active. So let's talk about the efficacy data. Why we're using it? What's the evidence of that? So preclinical data in animals has been going on for 1950s and 80s. So there are multiple paper on animal model and lab that they show that electric current can abort seizure. So that was the background. But the human data started in 1990s. And initially, interestingly, it was more of coordinate activation, like the deep, like deep brain or thalamic activation. So more like deep brain stimulator, but that's how they come, okay, can we stop the seizure with the electric stimulation? So after that, there was two seminal study that paved the way for this bigger study by Possoff in 2014. So he implanted, or their group implanted 50 patients with drug-resistant epilepsy. And out of that, 4 improved dramatically. Other improved too, but 4 improved dramatically. And that led to initiation of this RCT trial, which is called RNS System Pivotal Clinical Investigation. So based on that, it get approved for FDA. And let me go a little bit about that study. So it was a multi-center study, multiple centers in US were involved, which was double-blinded and randomized controlled trial. So it compared RNS versus sham, meaning that all of them had got the device, but half people got activated and half people not. So there were 191 patients with drug-resistant epilepsy. They have failed 2 or 3 medications. They have epilepsy is multiple foci or eloquent foci that you cannot do the surgery. So those are the patient population. So what happened? There was a 12-week blinded period after they put the electrode, meaning that in 12 weeks, half the patient was activated the RNS and current, and other half were not. And then followed by that 84-week open label in all of the patients will get activated the RNS. So results were, so in the blinded phase, the 12 weeks, the first 3 months when half was on, half was not, we don't know which one on. So the one that had that was sham group or not activated, 17% still respond, like the placebo respond. Maybe the device was there or whatnot, but that's a typical placebo response in epilepsy. But the one that have the activated, they have up to 37% response. The seizure do not go away, but that get better. And then later, when they went open label, they saw that the efficacy of that sustained. Even the patient who are getting sham, when they put them onto the actual current, and they started to improve. And then interestingly, they also noticed that there was significant improvement in quality of life, and which is not a brainer. I mean, if you control seizure, all of you know, if you control seizure, everything started to improve, their mood, attention, learning, quality of life, self-esteem. So that they noticed. So then I think more interesting thing is they did a follow-up analysis up to 6 years for these patients. They keep following and following. So, interestingly, I think there's a theme with all the neuromodulation that initially you put it, you may not see the response. But if you leave them on slowly, they get response. So could it be that whole brain is changing the circuitry and now it is less excitation? So, but regardless, so we saw that in VNS, we saw in RNS, and I will show you in DBS, they also noted that. So meaning that at 1 year, you see 44% response. At 2 years, the response increased to 53%. At 6 years, the response increased to 66%. So it's keep on increasing. And then during that, they noticed that the side effect was bleeding and infection during the implantation of electrode. None of them was like severe or life-threatening, but they are there. It's a complication from the surgery. You're putting the electrode in there. That's part of any stereo EEG or phase 2 evaluation. So, so that's one point is like over the time, slowly the neuromodulation improve. I think on the devil's advocate, other hand, I can say that we were all hoping that this is more targeted therapy. We are putting on the focus. We are right at the spot, which is active, and then we capturing seizure stopping. So we should be getting like 90 or 100%. So now we are talking about 66, 53. Is it similar to VNS? Okay. So that's, I think, the one of the frustration we as a neurologist get, like, we do all this and it still is not a cure. It's still, we're talking about the seizure control or seizure reduction to 66%. That we got a little bit, frustrated with that, but it's still, there are many patients who will benefit greatly with that because there's no other option, or they fail VNS, or there's no surgical option. Couple of other things to mention about the RNS. So just to remember, so in US, it is approved for 18 and above. It's not approved for less than 18. But in our practice and in the multiple other centers in US, they have used for children less than 18 years of age, down to up to 7 years. There are a couple of things to consider. That one obviously is insurance and everything. There's no experience in that. How do you do that? Secondly, I think the main thing that is theoretical or hypothetical is if you notice that you put that chip or computer on the skull, you the surgeon drill a hole and put it there. So theoretically, if the child brain is still growing, so how does it affect the growth and brain if there's a foreign body in the bone? So maybe nothing, okay, but that's one of the worry is. And the second thing is, I think this is coming more from the pediatric epileptologist perspective, that we put RNS on the eloquent cortex, or for example, my seizures coming from area that control my left hand. I cannot remove my left hand. I have to do work and type, and I'm in the professional. So I have to do put RNS because I cannot lose my left hand. Versus a child who's 4-year-old, he has the long, or she has the long life, 40 years, 50 years, and then plus her brain is plastic, so he still can take over the other side. So in the younger, one can argue that the resection is superior to RNS in that patient compared to adult. It's the equation is a little bit different, but there's something to just consider in the children. But we have many children who have this, they do well without any major side effects. Second thing I want to mention is that programming. So as I told you a little bit that it's not just the VNS programming, you come and then you interrogate and increase it. So it takes a lot of, for the first patient that I did, I actually talked with the engineers from the NeuroPace, and they came 2-3 times for 2-3 hour session just to orient me about software, how to read it. It's actually ECOG, like EEG on the surface of brain. So it has a lot of data, how to interpret that, how to analyze that, and how to make sense of it, and then make a changes on the stimulation. So usually my initial first visit are like 2-3 hours each time. Once we get this thing controlled, then it's like every 30 minutes, every visit. But yeah, so, and then if the patient live far away, they are not very adherent to this, all the visits, then it can fall apart, everything. So that's one thing to consider. And then I think on the same second point is we don't have exact parameters of how to detect the seizure on the EEG, and then how to stimulate it. That's more important. So we go by individual case to case. I will like to see some standardized automated mechanism to pick up seizure and then stimulate that. But as of now, it's just individual case to case. And the last thing I want to mention is that MRI. So MRI is contraindicated for the brain. You can do the body MRI, but not the brain. Same opposite to VNS, in which you can do the brain, but not the chest. So if really you need, you can do the CT scan and everything, but if you really need the MRI, you have to explant that the chip on the skull, not the electrode. So that's something to consider, okay? And then other advantage of the RNS aside from seizure is it's kind of like chronic ambulatory ECOG monitor. You are getting the EEG for months and years, which in the hospital, when we bring that phase 2 evaluation, we can do 2 weeks maximum. Surgeon started to, yell us at there's infection risk and this and that. So we remove the electrode, but consider this as this give an advantage of running it for, ever, years. And so we get a lot of data that actually help us understand epilepsy better. So we started seeing subclinical seizure. And the second point is interesting. So there's many papers they're showing that we know already, but this actually helped that there's a rhythm to the epilepsy. Some people have daily rhythm. Some people have weekly rhythm. Some people have monthly, like mostly in females, monthly they get more cycle. Some people have seasonal rhythm in the epilepsy. And that if you're doing the long data, then you're noticing, and they have published paper that individual get more in this time of day, this time, and then you can modify your treatment based on that. So actually not just individual, but it just help us understand epilepsy a little bit more with the long data. And then we can help, if you add another medication, it can see how the seizure is improving or not. You have the live EEG recording all the time. Last thing is a little interesting. I still have to see in my practice, but their case report that if you notice that someone has, you need one side temporal lobe, the best is the resect, especially is non-dominant. But someone has both side temporal lobe epilepsy, you cannot resect both temporal lobes. So you put electrode on both sides, hoping that you will control seizure. But at the same time, after 3 months, 6 months, you notice that, that 60% or 80% seizure are coming just from the right side, and left is quiet unless you take off medication in the EMU. So when we bring patient to the surgical or epilepsy, we take medication off, then you get seizure, which is not the habitual or typical seizure. But this way, you can actually try to see at home, typical seizure are mostly right or mostly left, then maybe a year or two later, you can open, okay, now we can take care of your 80 to 90% of the seizure, which is from the right side based on our long data. And then other one, we still either leave VNS, RNS or medication. So that's another advantage. People have written reports, case report, case series trying to. Okay, so last point to summarize. So there's no consensus on how to automate the automated seizure detection. So I'll mention it's individual based. I do it based on how I train to read EEG, what I see on that, and then what is the patient is saying. I wish there was an automatic software that can pick it. Second is on the more importantly, there's no stimulation parameter that we have to do for this kind of seizure. So we do trial and error. We go slowly and keep going up till we find it seizure stop. So I think there's one of my patient, we are still not able to find out. We are detecting seizure, but we are not able to get the right stimulation parameter to stop the seizure. Lastly, or thirdly, the prediction of events have not been established, like who are the patient who will respond the best with the RNS. Although we have like 4 or 5 years of data, and then people are, or even longer, people are looking into it. As of now, I think there's no right answer, which one are better. In our practice or in my practice, I think if someone has single focus or maybe 2 focus maximum, and it's on eloquent cortex that you cannot remove, then these are the better prognosis for those patients. Also, there's thought of younger, if let's say if you do at 12 or 14, they actually do better than the older population. And again, that goes with the epilepsies. Start early, treat early, hit them early, the chances of success is better versus the circuit keep on getting more and recruiting more circuit. Okay, but again, if you do very young, that also then risk and benefit. Why not do resective surgery, even if it's eloquent cortex? So that's the summary of the RNS, and I think it has used. We are using it a lot. We were hoping that it will be targeted therapy to stop, but I think it's more of neuromodulation, just like more than VNS or the RNS or DBS. So let's talk about the next topic, which is the DBS. So deep brain stimulator. Our colleague who are in movement disorder, they are very, very familiar with it all in Pakistan or US. So for the Parkinson or the other movement disorder, we have a lot of, I mean, not me, but the surgeon and the neuromuscular movement disorder specialist. They have a lot of experience in the deep brain stimulation. Bringing it to the epilepsy world, it was a new. We were all a little bit skeptical. Okay, why thalamus? The seizure is coming from the frontal lobe, so why targeting the thalamus? But it has shown efficacy. So underlying is there's a stimulating electrode deep within the neural tissue. That's why it's called deep brain stimulator. These are all depth electrode into the thalamus. And there's a theory is there's a functional reversible lesion of seizure node, and that can modulate the network dynamics or prevent seizure. I mean, we are causing the lesion with the stimulation, but they are reversible. They are coming in bursts. So that's the deep brain stimulator. Little bit of technical information. So there are 2 electrodes put on both thalamus, and then there's a very small hole, bolt in the middle of around the vertex area where the surgeon insert the electrode, one on each side, and then the wire is tunneled through the neck, through the back, and goes into the chest. So in bilateral stimulation is required. A couple of technical or practical things that if someone, usually the patient they fail VNS and then they're going to DBS. So then we put it on the right side. Then because left they already have VNS generator. The generator is slightly bigger, or I would say a little bit bigger than the VNS generator. So it can think of cosmetic reason for the young girls or the females. Although I talked with 1 or 2 girls, they were like, they wanted to get seizure control. They were not worried about the cosmetic reason, but thing to consider. Second is here, our surgeon do in 2 phases. First, they put the electrode, then second surgery, they put the generator, and then they connect with that. Other thing is there's usually the surgeon who are very much familiar with this, they usually do it. They are more with the movement disorder because they are doing this for the Parkinson for a while. So usually they train our epilepsy surgeon for the first couple of surgeries, and then the surgeon get comfortable using it. I mean, a little bit movement from the target can go to different nuclei and cause different effect than the anti-epileptic effect. So I think what I suggest or tell parents or patient is that go to the place where they do it a lot. So it's depend on surgeon hand to where it put it. There was one or two children that we put it. So usually it's both adult neurosurgeon and pediatric neurosurgeon. They go together because adult neurosurgeon are more familiar with how to put it, but the pediatric neurosurgeon are more familiar with the pediatric anatomy. So they do it in other center, they do it differently, but just this is experience of our center. Last point I want to mention is the open loop compared to the closed loop of the RNS, mean it's not recording and then it's firing based on record. Although you can do it somehow, you can train it. Okay, if you see this thalamic signal, you fire it, but essentially it's open loop. It's like BNS firing all the time. Okay, this is the X-ray of it. You can see that it's coming on both sides around in the thalamus. And then you can see these are the bright 4. These are the electrode that will be stimulating. You can do 2 at a time on each side. You can do top 2, middle 2, based on the follow-up MRI, see how you close you are, and then you can change it. You don't need to go with one. You can change and see which one gives you better response. Okay. Mechanism of action. So I think it's the same extension of the VNS. So VNS goes from the vagus nerve to the thalamus and the relay station. So, but the idea is what is the indirect vagus nerve? Why not we just direct the stimulate the thalamus? Thalamus is the relay station, and we think from the especially generalized epilepsy, Lennox-Gastaut, tonic seizure. So they have the thalamocortical connection. So can we disrupt that? So that's one. The second thing is there's also thought the anterior nucleus of the thalamus is also connected to the limbic circuit or Papez circuit. So the most of the temporal lobe epilepsy, they go through that pathway, the limbic system pathway. So you can disrupt that pathway. So it can not only work for temporal lobe for partial Papez or limbic system pathway, but also for the generalized epilepsies in which you are having these generalized bursts of activity, tonic seizure or atypical or absence seizure. And then the thought is like in animal model, they noted that if you lesion the mammalothalamic connection, or you give the high frequency stimulation, or you actually inject the GABAergic drug in between that connection, this will reduce seizure. So that's another theory that can we disrupt that circuit. Then in terms of coming to the efficacy data, just like we discussed all other. So this one has little timeline on go. So in 1960 or like before in 1960 and past, we noticed that the patient who had a subcortical lesion for movement disorder or there was some stroke on thalamic, their seizures seemed to get better. So that was just observation at that time. So then people started thinking, okay, is there a role of thalamus in that too? Then later in the 70s, in the cat anterior, like in primate model, cat anterior nuclear thalamus, they resected it and then this reduced seizure. Then they went into guinea pigs in 1994. And again, if you do the lesion, then they improve. So in 80s, then we started to begin the human research. So Cooper et al. Was the first one. He described the case series of human ANT, it's anterior nucleus of thalamus. This is the target that is currently approved. Based on that, in 2010, this is the Sante study that is only study randomized for the DBS, and based on that, it get approved. So basically, this stimulation of anterior nucleus thalamus for treatment for epilepsy. So since this study that got it approved, so let me talk a little bit about more, and then I think I'm almost end of my talk. So this was done in 2010. Again, multi-center, double-blind, randomized controlled trial for drug-resistant epilepsy, failed 2-3 medication, and not a good surgical candidate. So they have a 3-month baseline, nothing. Then 1 month they do after implantation, recovery period, then followed by 3 months of blinded. Like half of them got 5 volt, half of them was 0 volt or sham, and then went to open label. So results are showing that 40% if you are giving the current versus 14.5% if you're just doing the sham. Paresthesia and implant site infection are the thing they noticed, 10%, but not enough to remove the electrode. So there's no CNS infection or bleed as compared to RNS, which has, I told you, 2.7 to 1.7 bleed or infection. So these look like it's safer, but I think need a good surgeon hand. So they noticed that 1 year it was 41%. So I think that's another point I want to mention, that over the time it improved. So initially, when they present 1 year, 41% FDA said, that's nothing. We are making patient go through a lot, and it's still the same. So then after 5 years, they showed that now it's 70%, and then out of sudden in a 6 month, FDA say yes, you can approve it. So I think the timeline helped them. So this is again the device, and usually same as VNS is a programmer that come with the Bluetooth, so you can. Here you can see you can stimulate each of the electrode. You can tell which electrode, and then you can increase the current just like anything. Currently approved for patient 18 years of older with drug-resistant partial epilepsy, not for generalized. But I will be honest, as off-label, we use for generalized. We use for children less than 18. Okay. A couple of things about the target. So it's approved for anterior nucleus or ANT target, which is here. But there are other, why can't we do the hippocampus? So people have done it, their case report. So here, if you can put just like in the hippocampus, go all the way down. The problem is they noticed that Cochrane review that if you do hippocampal, that is not superior to ANT. So maybe just put ANT, which is approved FDA. Then second is the centromedian nucleus, which is, if I can, show it's centromedian is around here. So interesting thing is from the pediatric perspective. So this will block the pathway for the thalamocortical junction, not the limbic system pathway. So it's good for Lennox or tonic seizure, refractory myoclonic or generalized absence seizure. And this is all off-label use. Then there are other two, subthalamic nucleus. You can do overstimulation of white matter, but these are not studies. These are all off-label use. Potential complication, implant site infection, malposition of lead, and paresthesia because just by putting the electrode, not by the activation of the current. Battery life is there two ways. You can do the non-rechargeable, which is like VNS 4 to 6 years, or you can do rechargeable, which is every 9 to 10 years. Both are option is available. So I think I will not go in detail of this, but this is a summary of comparing all three. I think in the very simple way or summarize it. So I will, usually medication is the one that we treated if it's working good. On the other hand is surgery, which I think is cured. Then if we cannot do either, then in the middle, we can do VNS, RNS, or DBS. VNS usually good for partial, generalized, all kind of is non-invasive. You're not opening the brain. So you can do VNS, it may work, it may, and if not, then you're not opening the brain. Versus deep brain stimulator is same, but you have to put electrode in the brain. You don't need any other investigation. You just put electrode in the brain, and then it's also closed, open loop. Responsive RNS is a closed loop. It detects seizure and fire it. The problem is you have to find the area where to put the electrode. So a patient need the phase 2 evaluation to find out, and then go from there. And then I think most of the thing I discussed in the other previous slide in terms of seizure freedom, MRI, complication, and side effects. So this is but summary of one of the paper, how we summarize comparing all of them. Okay, so I think the last one, last point I mentioned, other neuromodulation, again, for the interest of time, I will not go, but just throwing it up that these are the other options. Transcranial magnetic stimulation is not approved by FDA, but people are doing a lot of studies and a lot of things how to control seizure, because it's an RNS, but you don't have to go through the skull because the magnet current go through the skull, but electric current cannot. Then you can do trigeminal nerve stimulation. You can do non-invasive vagus nerve without putting the implant. You just put the auricular nerve. There's a device that whenever you feel seizure, you put on the auricular branch. And then you can do actually direct current stimulation. So these are all experimental. There are case report, case series, but none of them are FDA approved. I think the summary is this is the path people are going for, especially when medication are uncontrolled and you cannot do surgery. The neuromodulation has very promising role on it. And we just need to learn a little bit more about it. What's the best parameter? All right, so I will finish with that. And with that, I will say thank you again for the opportunity to come and discuss this with you. And this is a video recorded lecture, so I'm not there in person, but this is my email. Feel free to send me an email if you have any question about the thing I talk or any other thing, if you have a case you want to discuss, is it a good candidate or not, I can guide you. If someone wanted to set up a center, VNS, RNS center, they need help, I can guide you with that. or if you have a patient that you wanted to refer to here to get this procedure done, and they can follow up with you. So I'm happy to help you anyway. Okay. Again, thank you to organizer and all of you for listening and giving me a chance to talk. Thank you very much and have a good day.